Bismillah Rahman Rahim and Assalamu Alaikum. I am Dr. Safdar, Professor of Urology, IMC. We are starting with a very important topic, that is BPH, benign prostatic hyperplasia. This is the prevalence of the disease. Just see that with the advancing age, the level of BPH or the prevalence of BPH increases with age, and it's about 90% at the age of 80 years. So with increasing age, it's also increasing. So this is the coronal section of the bladder and the prostate. This is bladder and this is the prostate, right? And this is the verumontanum and this is the external sphincter. So the anatomy of the prostate, or the zonal anatomy of the prostate, it consists of 5 lobes, 2 lateral lobes, 1 median lobe, 1 anterior lobe and 1 posterior lobe. Pathological anatomy, it consists of a transition zone and a central zone and the peripheral zone. It's a pathologically, from the transitional zone is mostly the BPH arises, and from the peripheral zone it is most the carcinoma prostate arises. This is the sagittal section of the prostate. This is bladder. This is urethra, prostatic urethra, and this is the central zone, and this is the peripheral zone where the carcinoma prostate arises, and this is the transitional zone where the BPH arises, and it is very it is just around the prostatic urethra. The same, the sagittal section, this is the urethra, right, and this is the transition zone. So if the transitional zone starts proliferating or increasing in size, it will compress the prostatic urethra and will lead to certain signs and symptoms. Again, this is the transitional zone which has grown up as we see from the normal in the previous slide. Etiology of BPH. Not completely understood, but androgens and age play a definitive role. Several hypotheses have been put forward. DHT hypothesis, with increasing age, that the dihydrotestosterone receptors, they become more active and lead to hyperplasia of the prostate. Estrogen testosterone imbalance. Normally there is a balance between the estrogen and the testosterone, but with increasing age, the testosterone decreases and the estrogen increases. So this imbalance may also lead to BPH formation. Stromal epithelial interaction. Normally there is a definitive interaction between stromal or epithelium, but some or other, under the different circumstances, with increasing age, the epithelial component starts increasing more as compared to the stroma and lead to BPH. Reduced cell death. This phenomena is called the apoptosis, that with increasing age, the cells, they die out. Normally they die out. The cells with age, they die and new cells are produced. This is called apoptosis. But in BPH, this apoptosis, the degree of apoptosis decreases. So the cell formation is more, but the cell death is low. So it leads to the development of BPH. And then there is a stem cell theory, that the stem cells normally present in the body, they start forming the epithelium of the prostate. So this is the normal bladder and the prostate. BPH is the most common neoplasm in men, found in 50% of men in their 5th decade and in 90% of men in their 9th decade. The etiology of is multifactorial, which we have the different theories we have just discussed, but there are 2 essential prerequisites: the presence of testes and the aging male, and this is the normal bladder and this is the normal prostate. This is prostate, yellow one is the prostate, and the lumen in between is the prostatic urethra. This is the BPH, obstructed BPH, I mean, if the BPH is left untreated, what will happen to the urinary system? This is the enlarged prostate leading to back pressure. What would it happen? Irreversible changes in the bladder. The bladder wall becomes thick. It will lead to irreversible changes. Thickening of the bladder wall, recurrent hematuria from the prostate, bladder diverticulum formation. There are different diverticuli formation inside the bladder wall. Repeated urinary tract infection. Due to BPH, there is residual urine. The urine is not evacuated, bladder is not evacuated 100%. There is residual urine, and which leads to the infection of the urine. And then, if this infection continues, the bladder stone formations. These are called secondary bladder stone. And if this residue, back pressure continues, it will lead to the back pressure in the ureter alveoli, and it will lead to the dilatation and ultimately the renal failure. So, development of BPH, like this is the transition zone, and this is the actual prostatic tissue. With increasing age, the transitional zone starts increasing, and the actual prostatic tissue is compressed against the normal capsule of the prostate, anatomical capsule of the prostate. So the similar, another enlarged prostate. This is the transition zone which has grown up, and this is the actual prostatic tissue which has been compressed against the adventitia of the anatomical capsule of the prostate. So obstruction is in BPH is twofold. One is mechanical compression by the adenoma increasing prostatic tissue, and number two is the dynamic component of the obstruction, which is due to increased sympathetic activity of the prostatic smooth muscle. The normal smooth muscle of the prostate becomes overactive. So this is the mechanical or the physical obstruction. This is a bladder, and this is the prostatic urethra. Due to enlarged prostatic lobe, the urethra is compressed and will lead to obstruction. Dynamic component, this is the normal prostatic tissue, and there are sympathetic open nerves inside this prostatic tissue, and these due to overactivity of these sympathetic nerves, the tone of the prostate is increased. So it also leads to the compressed prostatic urethra. What is the clinical presentation? There are two sort of symptoms. One group is called irritative symptoms, another group is called obstructive symptoms. So how these lower urinary tract symptoms should be evaluated? By medical history, there are international IPSS questionnaire, International Prostate Symptom Score. So there are total 7 scores. Each score has been graded in from 1 to 5. So by taking the history, one can fill in the pro forma and can gauge what is the actual prostatic symptom score. 0 to 8 is the mild, 8 to 18 is the, and 9 to 18 is the moderate symptom score, and 19 till 35 is the severe prostatic symptom score. And first is the medical history, and the international prostate symptom score. Then is the physical examination and digital rectal examination. One can examine the patient and can have some idea of the prostatic enlargement by looking into the urine analysis and the serum PSA. Normally it should be less than 4 nanogram per ml, but if it is more than 4 nanogram, then one should become suspicious. And this is the international prostate symptom score. There are 7 symptoms. Each has been categorized or graded into 1 to 5. So 7 symptoms, 5 grades. So the maximum prostatic symptom score can be 35. and quality of life due to urinary symptoms. This is also important, how the patient reacts, how the patient feels towards these symptoms. What are the standard tests? Urine analysis, renal profiles like BUN and serum creatinine, PSA, prostatic specific antigen, and then the voiding diaries. I mean, how the patient is, the lower urinary tract symptom, how the patient is doing on the medical therapy. One has to keep the charts, and then is the ultrasonography. There are certain optional tests like the flow rate recording, uroflowmetry, residual urine. How much residual urine mean how much urine is left behind inside the bladder after voiding. Then certain pressure flow studies by urodynamics where the contractility of the bladder can be measured. Transsectal ultrasonography can be done to visualize the prostate, and previously we have been doing IVP, but now it's not done. And then during endoscopy one can have the idea of the prostate, whether it is enlarged or not, and what is the bladder inside. So digital rectal examination, what to look for: size of the prostate, width and length of the prostate, consistency, whether the prostate is smooth and elastic, which is normal, or hard or woody, it would indicate cancer. Tenderness of the prostate suggests prostatitis. Mobility of the prostate, whether the prostate is fixed or it's mobile. Fixed prostate is due to carcinoma of the prostate, and mobile is the normal prostatic tissue. Anatomical limits: fingers used to try to reach lateral and the cranial borders. Seminal vesicle should be impalpable. Duration of these suggests malignancy. Post-voided residual urine, it means how much urine is left after voiding. So normally at the age of like 60-70 years, it should be less than 100 ml. So if the residual urine is more than 100, look for some pathology, either prostatic or bladder or detrusor contractility problem. Same. So what are the therapeutic options left? What to do with these patients? Watchful waiting, medical therapy, surgical therapy, laser, tuna. Tuna is transurethral needle ablation, thermotherapy, high intensity focal ultrasound, intraurethral stents, transurethral balloon dilatation. Normally we use watchful waiting, certain drugs are used, surgery is done, laser is also being done. Tuna is done very not routinely, results are not good, but in unfit patient one can do tuna. Thermotherapy is no more. High intensity focus ultrasound used to be done, but results are not good. Intraurethral stent, yes, in unfit patient, biodegradable stents are placed inside the prostatic urethra, and with time they open up the prostate, and the patient starts voiding. Balloon dilatation used to be done, but the results are not good. So the BPH, for mechanical compression of the adenoma, the surgery is the choice. For dynamic, to overcome the dynamic obstruction by the sympathetic overactivity, the medical therapy is the answer. So what are the absolute indication for prostatectomy or TUR or any surgical intervention? The absolute indication is the untreated BPH. Like if the patient is left untreated, it will lead to urinary retention, recurrent hematuria, bladder diverticulum formation, repeated urinary tract infection due to BPH, or bladder stone formation, secondary to distal obstruction, upper tract dilatation, and the renal impairment. This is called untreated BPH, and this is the absolute indication for surgery. And the relative is like the post-wide residual volume. If it is remains, patient has symptoms and the volume is more 100 ml or 200 ml, probably that patient should undergo surgery. Like the symptom score, if the patient is severe, symptoms are severe and there is no effect of medical therapy, one should go for the surgery. Flowmetry, if the Qmax is less than 10 milliliter per second, probably that is a severe obstruction and patient should undergo surgery. And the prostatic size exactly is the relative. The bigger the prostate, the patient is more likely go into urinary retention. So symptoms with bigger prostate is a relative indication for surgery, and symptoms with smaller prostate, probably there are less chances that the patient would develop urinary retention. So what are the indications for medical therapy? Uncomplicated BPH, no absolute indication for surgery, which we have just discussed, which is an untreated BPH, and medically unfit patients. This is the indication for medical therapy. Uncomplicated BPH, no absolute indication for surgery, and medically unfit patients. So this is the for medical therapy. For what is the medical therapy? For bigger prostate, 5 alpha reductase inhibitors, and the alpha blocker. These are for bigger prostate, and for smaller prostate, we give alpha blockers, and sometimes the combined therapy is given. We start with both the drugs, 5 alpha reductase inhibitors and the alpha blockers. And when the symptoms are improved, we stop the alpha blockers and continue with the 5 alpha reductase inhibitors. 5 alpha reductase is an enzyme which converts testosterone into DHT, dihydrotestosterone. Dihydrotestosterone is the end product which combines with the receptors on the prostate and leads to its proliferation. So if we can stop conversion of testosterone into DHT, that would result in decreasing or the size of the prostate. So finasteride and dutasteride are the two drugs which inhibit 5 alpha reductase. And by alpha blockers, there are many alpha blockers which block the sympathetic overactivity in the prostatic smooth muscle. So there are by this mean we can block the dynamic component and the patient's symptoms would be ameliorated. This is so 5 alpha reductase inhibitors blocks the conversion of testosterone to DHT, affects the epithelial component of the gland, should be given in bigger prostate where the prostatic size is more than 40 grams. It reduces the prostatic size and the symptoms. Minimum 6 months therapy is given. Side effects include decreased libido, ejaculatory volume, and the potency. There are a few cases of developing impotency. Efficacy, safety, and durability of this treatment is well established. The rationale for alpha blockade, functional predominance of alpha 1 receptors in human prostatic muscle, blockade of the motor sympathetic nerve supply to the prostate reduces urethral pressure, it reduces the dynamic component of the smooth muscle of the prostate, is usually indicated in smaller prostate. Side effects of alpha blockers: dizziness, headache, asthenia, drowsiness, postural hypotension, and retrograde ejaculation. Combined treatment usually indicated in bigger prostate. We start with 5 alpha reductase inhibitors and alpha blockers for 3 to 4 weeks. Then we withdraw the alpha blocker and keep on with the 5 alpha reductase inhibitors. And this is the instrument resectoscope which is used for doing transurethral resection of the prostate, which is the gold standard. Thank you very much.